Thank you to everyone for joining us for Lupus Canada's Let's Talk Lupus webinar. I'm honored to have the privilege to introduce Dr. Cheryl Barnabe today. Dr. Barnabe will be discussing lupus and the Indigenous population. Dr. Barnabe is a Métis rheumatologist and a Canada Research Chair in rheumatoid, arthritis, and autoimmune diseases. She is a professor in the Department of Medicine and Community Health Services, Cumming School of Medicine, University of Calgary. She is a vice chair in the Department of Medicine, Indigenous Health, and the deputy director for the McCaig Institute for Bone and Joint Health. I just want to start with a few housekeeping items to address before we begin. Everybody has been placed in listen-only mode. Therefore, your audio and video are off. And should you have any questions, though, throughout the webinar, please put it in the chat box and we'll address those at the end of the webinar. We hope you find this informative. I will now pass this over to Ariana Ranjabar, who is our moderator for today's webinar. Ariana?
Thank you, Leanne. Yes, hi, everyone. My name is Ariana. I'm the moderator for this webinar. If you have any issues throughout the webinar, please put it in the chat box. And if you have any questions, we'll address them at the very end of the webinar. And thank you everyone for joining us. I will now pass it along to Dr. Barnabe. Thank you again for joining us.
Well, and thank you very much for having me. I admittedly am a rheumatoid arthritis researcher, and I don't even know if I've ever actually given a lupus lecture before, so please bear with me, but my area of expertise certainly is in Indigenous populations and arthritis care, and so I do hope I can share some pearls and some wisdom today for us all to help expand our knowledge of how we can become allies. First, I'd like to just start with a land acknowledgement. Everyone on this webinar is located in a different place. I'm speaking to you from Treaty 7 territory, which is home to the Blackfoot Confederacy, which includes the Siksika, the Piikani, and the Kainai Nations. Treaty 7 is also home to the Goodstoney First Nations, which include the Chiniki, Bearspaw, and Goodstoney Nations, as well as Tsuut'ina Nation. And I'm also located in territory that up until last week was home to the Métis Nation of Alberta Region 3. We're now recognized as the Otipemisiwak Métis government, which is brand new and self-determined. We have beautiful land here, and I also wanted to extend my appreciation to where everyone else is today, and hope you can take a moment to think about the territory that you are residing and living on. I also, this week, giving this presentation this week is purposeful. It is Truth and Reconciliation Day this weekend. And I'm hoping that we are all approaching this in that spirit of reconciliation, which is not only a process of learning, but is also a process of building relationships between nations and understanding where those relationships have been strained over the years. It's a place where we have to start thinking about the actions that we take to address colonialism and all of the consequences of it, and then all take an approach that will build a society that is focused on inclusivity and equity as well. And that is certainly what I hope to do with my work as I continue on throughout my life as well. So first is to understand Indigenous populations. And I think perhaps we get a sense that, there are, an Indigenous population worldwide, or there are 3 different Indigenous populations in Canada. But the Indigenous population, both globally and in Canada, are substantial, accounting for about 5% of the population. Certainly in Canada, a large proportion of that is under the age of 14, so that population will continue to grow over time. The second thing to know is that there's a significant amount of heterogeneity between nations. So in Canada alone, we are talking about over 600 First Nations governments, the 8 Métis settlements in Alberta, and then also 4 regions with 53 communities in Inuit Nunagat, which does not even speak to all the urban Indigenous population in Canada either. So while I'm presenting this as a very homogeneous approach, it certainly needs to be taken into consideration that each individual nation has its own language, its own culture, its own customs. And so how we approach healthcare delivery and seeking lupus care, or more broadly arthritis care across, will vary depending where you are. What does unite Indigenous peoples globally as well as in Canada is that we all have a common experience of colonization. So when we speak of colonization, we are speaking about the deliberate actions taken by a government, such as the British government or French government, if they had one, back in the 1800s, but comes in and imposes their structure, their rules onto a population that has been residing in a location before them. And the purpose of colonization is to take over control, is to take over power, to take over resources. And one of the ways that that is done is through rules, regulations, legislation, law. And so I've got on the slide here 2 examples of some of these laws and documents that have affected Indigenous populations. The first is from the Indian Act of 1876. So between the formation of Canada in 1867 and then the creation of the Indian Act in 1876, there had been a large volume of scattered rules and laws that were applying to Indian populations as they were known then. And these were all consolidated under the Indian Act in 1876. Some of the rules that were placed forward in this Indian Act included the inability to actually own land anymore, outline of certain customs and practices, and also removal of First Nations status for women who married someone who was not First Nations. So those were some of the things that were done to help along in that assimilation strategy that the Canadian government had at the time. On the other side is my actual family script from the Red River region in Manitoba. And so Métis script was one way of also saying, well, we know you're desperate. We'll give you an entitlement to some money or a certain piece of land, but it never designated where that land was. And so people could be forcibly removed from where they had settled, even though they thought they had the right to settle in that location. So these types of activities have happened over many decades and over hundreds of years to try to assimilate and remove the self-determination of Indigenous populations. When we think about those impacts over time, you can think of how this has affected educational attainment, how it has affected people's roles in society, how it plays out with gender differences. We can think of all of those determinants and how it might have resulted in changes for one population over another. When it all boils down to it, to me, life expectancy is probably one of the most important indicators of those ill health impacts of colonization. How long you live reflects your ability to have a good environment to live in, to attain the education that's needed, to have income to get to the resources you need, for example, for covering medications. And so all of the things that you have in your life contribute to how long you live. And in Canada, this data is specific to First Nations in Alberta, but where we look at where general population society, which is the blue line on this graph, life expectancy has only increased over the last 20 to 30 plus years. People live longer. They have access to medications to help prolong life. They learn things to help maintain a healthy lifestyle. For First Nations people in Canada, life expectancy has not changed whatsoever. So it has remained completely flat, and all of those gains have not been realized, which actually makes that difference between the top two populations only grow larger, and ultimately reflects what is happening from a societal and economic and legislative perspective to continue to assimilate Indigenous populations. So I'll switch gears to understanding now how lupus specifically affects Indigenous peoples in Canada. And the only 4 studies I could find are very old. This is not good contemporary data. A variety of different methods have been used to try to figure out how many people do have lupus in Canada. But I will present what is available. The first study I want to speak of first is where I'm referring to the Neutral North people. We also have a terrible legacy of inadequate and improper research ethics in Canada, but also specifically in rheumatology. And so this study is one that is quite caused significant harm to the Neutral North population that has been redressed in most recent years. But I do want to acknowledge that the data obtained from that study was not done from an appropriate relationship or ethical perspective. However, it certainly demonstrated the high rate of lupus and other connective tissue disorders in the Neutral North population of British Columbia. We also had done a study back, I think it was about 2012, to look at Alberta data. Alberta is one of the few provinces, aside from Manitoba, where there has been a population indicator for First Nations status. And so when the appropriate research agreements are entered to with the overseeing bodies, such as in Alberta, at the time, the Alberta First Nations Information Governance Center, we can look at the health data and figure out on a population level, so looking at the entire province, how many people from different populations have different conditions, including lupus. So in Alberta, the population is largely comprised of Blackfoot, Cree, Nakota, Sarsi, and Saulteaux peoples. And in Alberta, about 27 out of every 10,000 females from those communities have lupus, and the rate is 3 per 10,000 in males. And that's actually pretty similar to what we see in the non-First Nations population in the province. However, when we looked at separating out who has lupus based on their age, as well as their sex, and then as well as where they reside, twice as many First Nations women over the age of 45 will have lupus, and that is compared to the non-First Nations population. So there is some sort of birth cohort effect or an environmental exposure. We really don't know why that elevated rate occurred in that specific group of women, but it is certainly one group that we see an elevated prevalence of lupus. A similar type of study looking at a population-based database was done in Manitoba, which is primarily comprised of Cree and Ojibwe women and people. And for First Nations women, the rates of lupus were twice as high as compared to non-First Nations Manitoba. And then the last study is one that was done back in the late 1970s, early 1980s, which was more based on a case finding approach within Inuit communities in the north. And this was in the former Northwest Territories, which is now Nunavut in the Northwest Territories. And over 4,000 people were assessed and no cases of lupus were found there. So, I'm certain if we repeated this type of work, we would actually find that there is certainly lupus in the north. But again, these are limited availability of data that we have. The next thing to think about is how lupus affects Indigenous peoples differently. And what I've presented here again is not the most recent data, but is from a compilation of different studies that have been done over time. And I've placed some of the different features of lupus on the table here and what frequency has been reported in a variety of different studies. Now, we see that there are a certain frequency of different presentations, and some of these are different than what we see in non-First Nations populations. So for example, the arthritis component of lupus is extremely frequent in First Nations and Indigenous, if we're also considering that broader group that includes Métis and Inuit in it. That small joint arthritis is significantly more common. We see that about half of people will have some of those rash features of lupus that occur, or the oral ulcers in the mouth that can occur. And yet we see less frequently renal disease, which is a good thing, because obviously renal disease is quite complicated, can lead to significant difficulties with your health status over time. So there are some differences in how lupus presents. One of the most recent studies that has been done was the 1,000 Canadian Faces of Lupus study. And Dr. Christine Peshkin, who is one of my mentors from back when I was training in Manitoba, led this study and was able to look at the differences for lupus in people who reported that they were of Indigenous ancestry compared to not. Now, what she found in that more recent study was that the comorbidity index, which is reflecting how many conditions and systems are affected by lupus, it is higher in women who, and sorry, I keep saying women, but women mostly, and also some men, have a higher frequency of those comorbidities. So consequences or other diseases that are occurring in conjunction with lupus. In the study, the amount of kidney involvement was similar to people who were from the white population. But there was a higher frequency of those rashes that were occurring, as well as some of the severe complications of lupus, which include vasculitis, which is when the blood vessels are inflamed and can rupture, which obviously leads to bleeding in places it should not bleed. And then mononeuritis multiplex, which is an inflammation of the nerve, which then causes the nerve to not function properly anymore. One of our ways of monitoring lupus over time and also helping to make that diagnosis is to look for markers of it in the blood. And so in the 1,000 Faces study, women and men who had lupus who were Indigenous had a higher frequency of double-stranded DNA antibodies, which is a marker of disease activity, as well as antibodies associated with antiphospholipid antibody syndrome, or a clotting disorder that can go along with lupus. And overall, even when the medications were looked at and people were having access to all the same medications, disease activity remained higher for women and men with lupus in this 1,000 Faces study. Now, putting this talk together, as I said, I don't work often in the lupus area of research, but I found a lot of things I don't know about lupus and Indigenous populations myself. And this is understanding what lupus is like for Indigenous peoples. What do we know about the outcomes over time? What are the challenges faced in accessing care for your lupus? What are the other things that you need to help survive with lupus and live as high quality of life as possible? What are some of the resources that are needed? What are the things that we can do to help protect your health and wellness through that disease journey? And what are the things that make seeking care easier? So these are all things I do not know specific to lupus. And I was going to invite people, if you wanted to put into the chat some of the other questions you have about lupus, specifically affecting Indigenous peoples. We're happy to have some of those shared here. And as you're putting those in the chat, these are some of the things I will talk about today, but I'm going to be extrapolating from the rheumatoid arthritis literature. We see that there's a lot of commonalities between chronic diseases in Indigenous populations. I work with many people who work in diabetes care, dementia care, renal care. And so we see the same patterns repeated over and over, which is why I feel fairly comfortable talking about this. But again, if you have ideas of things that we need to know and learn about, I can speak about that in the Q&A session at the end as well. I'm not sure if Ariana, if there's anything coming in or not, but
we could just wait a few moments and then hopefully people will put something in the chat box.
All right, I'll move ahead though, just in case people are making decisions here. One of the things we do know though, is that regardless of what type of condition you have, whether you have a condition or not, where you live, who you are, Indigenous peoples worldwide have the right to access healthcare that is high quality. They have the right to use what is needed to help support that health and wellness, whether that be traditional medicines, traditional health practices, using Western-based approaches to medicine and health. All of those things should be attained and be done without any discrimination against. And that is one of the things that we have to really advocate for within our current health systems. It's more than hospitals, it's more than clinics, it's more than medications. It's about that entire health approach to health and wellness that we need to hold. But I will speak to some of the sources of where inequities in health arise from in our health system. And there's multiple different levels when we think about it, and all of these are influenced by politics and funding systems and legislation. So first, if we're thinking about the health system proper, it is the government that does decide how much money is transferred over to health, how that is distributed to provide services, what are the different policies governing health and access. Do we have health systems that are actually culturally safe? That is something that is determined at that health system level. The health system also controls who brings their abilities and resources to work within the health system. So who is it that we recruit? Who is it that we support to attain training to work within a health system? And then also what the health system can do is look at where gaps are in care and start to put into place some improvements or some quality changes into the health system. So there's that will and there is that ability that we want people to take to start to change the health system, because it is not sufficient at this current time. Within those health systems, we have health services. And so this might be how systems and services are provided more at that regional level or community level. So we might receive money from the health transfer from the federal government over to the provincial government. Provincial government decides how it's distributed, where those resources will be put. And then that determines what programs are put into place in a certain area. So this might be how rheumatology care is structured within the province you live in, for example. And most of the times, the Indigenous and First Nations health systems may be a part of the health service, or they may be separate from it. And so there's that ability and will, again, that we're asking for health services to think about how they partner with First Nations communities who are providing care on reserve, for example. Or again, how are people being recruited and selected to work within healthcare? Are there ways that we can help to build capacity within the health service? Or do we actually provide funding over to a place to provide its own programming and under that guise of self-determination? We know the programs that would work best in this area. Please let us deliver them, is one aspect that the health service could do. And that, again, takes will and desire for someone to do. Then there's that clinician level, which is how, as an individual provider, we actually approach our practices, how we start to build relationships with our patients, how we communicate, how we go ahead and actually learn about reconciliation for ourselves. Those are all things that we, as individual practitioners, could be doing. And again, it's about what is our will, what is our desire to learn. And if we're not doing those things, that's where we start to build in inequities in the health system. All of this is overlaid with the societal aspects, which include those larger social determinants of health I spoke of. So education, environment, sex and gender, culture, all of those things are influenced by how society is structured. We know that discrimination and racism is present everywhere in society. We give opportunities to particular groups, not all of them. And we also impose our knowledge systems. And so from a colonial government perspective, with a very Western focused knowledge system, that is what is acceptable. That is what is normal, has been normalized. And then most of the time it's to the exclusion of Indigenous knowledge systems and approaches. And so we see a difference in what is funded and what is not, for example. And these are all things that drive some of these differences we see in health over time. So many, many years ago, I started working out at Siksika Nation. And then I also started working in an urban Indigenous clinic. And then I started working in different reserves as well to provide rheumatology care. And we would see, starting out there as a relatively new practitioner, I was trying to understand what was happening in terms of what we were seeing clinically, observing things around follow-up care, and trying to make some improvements. So this is the overall model that I'm going to walk through. I just wanted to first present it as an overall view of where things are at. But we recruited both patients and healthcare providers to talk to us about what is happening in the health system, and for people with indigenous people who had a variety of different arthritis conditions. So I'm going to first speak to what the health providers told us. Now, health providers are employed by health system. They've been trained in a Western model, and so they are very much attuned into the professional expectations of their discipline. So, for example, physicians are typically groomed to provide a 15-minute follow-up. You're going to provide maybe 30 minutes for a new patient visit. You have a slate of patients that have to be seen every day. And so that is what is driving you, is that expectation that's been put on by our professions to be able to see people, see a certain volume, document that visit in a certain way, and provide an evidence-based healthcare visit. When we were asked healthcare providers about their impressions of what was happening with Indigenous clients and their practices, the majority would say that they were very much frustrated that people were not doing as well with their disease state as could be happening. And this was framed around having an expectation for people to come to follow-up visits, follow up on the advice that was given to them, get the lab work done, take the medications that were prescribed, and then come back and do it all over again. And that does not necessarily happen all of the time. And that's where I'll present the other side of what people are trying to avoid within healthcare. But it was frustrating to health providers. They felt as though there could just be so much better outcomes happening, and they weren't happening, and they were placing that blame back on the individual Indigenous patient. And then also health providers, we all kind of go into this because we want to help people, we want to make a difference with their health status, and people really genuinely want to provide high quality care, but they feel very constrained by the health system that they work in. So they are expected to see a certain volume of people a day. They are expected to do certain things, and they don't feel that they can deviate from that very often. So all of this puts them in a frame of feeling like there's just very poor buy-in for seeking health approaches and seeking health. And they feel, and then what would happen is that if one patient was like this, and then a second patient, it started to create this creep of impression that, oh, well, everybody from this community is like this. And of course, this is extremely dangerous. This is where we run into big, big problems. And so is something that we needed to address. And I'll talk about that in a moment. Now, I want to present the other side of this. And so we were hearing all of the stories from healthcare providers saying, well, the patients just aren't buying into what I have to provide them. And so it created this impression on the provider side too, that maybe people just didn't really care about their health. And that is absolutely incorrect. So of course, arthritis causes pain and has significant consequences for Indigenous people too. But they are living in a situation where they also have multiple other conditions that at times are more serious than living with daily functional consequences of arthritis. So they have diabetes, and maybe they're dealing with a foot that is infected, or perhaps they're living with severe mental health challenges, and those will take precedent over a chronic disease such as arthritis. There is also the aspect that because arthritis conditions are so very common, and because they tend to cluster in families, arthritis is seen as something that just happens over time. It's very normal. Why would I go to see healthcare providers for a condition that everybody has and is something that's going to happen over time? So there was also that misconception that there was really nothing that could be done. And then, of course, what really predominated was the stories of racism, of stereotyping, of discrimination that people had faced in the past, or that their family members had faced in the past when they were trying to interact with the health system. And very, very harmful experiences had occurred for many people, which would actually lead them to what we framed as this tough it out. So it was better to just tough out the symptoms of an arthritis condition than to seek care for it, because it was so dangerous and detrimental to actually contact the healthcare system. And so then this is where the two sides really clash. So the providers have a certain expectation of what patients will follow and do, and the patients have had terrible experiences and have lots of other things going on in their lives. And so that creates that clash of one group saying you should be here, and one patient, and the patient group saying I don't want to be here. And so that's what we really have to try to come together on, is around how to get out of that cycle. And so we ask people, what are the things that we should be doing as solutions to this? And one aspect of it was to actually create a safe environment for people to seek care in, which means that we have to change the knowledge and the culture of medicine. And we also have to work in different ways. So let's work around difficult, inflexible systems to actually create a healthcare service that better meets the needs of patients. Now, I come from a research background and was able to work on aspects of engagement for research perspectives a few years back. And we walked through what are the ways that researchers should be interacting with communities or interacting with individual patients. And that's not what I want to focus on today, but what the overarching themes were in this work is that we're actually working to create partnerships. We have to build trust. We have to earn the trust of patients, and we have to be reflecting all the time about every interaction we have. Was my language safe in that interaction? Did I really listen to the person? Did I really try to meet their needs? And so it's not just going in and doing the usual. It's about actually taking that moment to practice in a different way. And so as we were doing this work, a colleague of mine here at the University of Calgary by the name of Dr. Lindsay Croshoe was working on an Educating for Equity program, which was to be delivered to first primary care providers who were helping patients with their diabetes care from Indigenous communities. And so as I'm hearing all of the stories from the arthritis world and then seeing the actions that he was proposing for diabetes care, it was just this natural, union of, hey, you know what, this would really work for the rheumatology setting as well. And so I was able to work with him to create a program specific to rheumatology providers based on this Educating for Care, for Equity care framework. And there's really two aspects to this program, and I'll walk through these in a second. The one is to talk about that relationship and refocusing our efforts on creating a strong relationship with patients. The second is around understanding the social realities of patients, thinking about the detrimental sides of colonization that have impacted how we have learned to do that in medicine, and bringing in culture as a facilitator for care for all of these. So I'm going to give a few more slides here about this. So first is on recentering relationships. And so what we teach in this educational forum for providers is that the very, very, very first thing that must be done is about creating relationships. And it's about that reciprocity. So sharing, it's not just a one-sided, please come in, tell me all of these very personal things about your health and your life, and I'm not going to share a single thing about myself. You need to build and create that this is actually a sharing. And of course, I'm not going to be sharing, my health status. That's not the approach that we want. But it's around creating that connection. So, hey, I'm also from that community, or I've been out to where you're speaking of, or, sharing those experiences to help discuss that. process in place refers to the time that is given. So we cannot be working on these like automatic clocks and having all the pressures of the time clock on us when we're meeting with people. Pausing and letting people have a moment to collect their thoughts and share them if they want to is important. We're very quick to rush the discussions, and we have to stop doing that. And then connectedness is creating that relationship over time. So if someone shares with me, for example, that they've been very proud that their family member was selected for a recognition, or has finished schooling or something like that, it's about bringing that back into the conversation again the next time. So not just again this passive like, oh, another person. It's about actually remembering what you've talked about and bringing that back to keep engaged with the patient. We have to remember that from that aspect of colonization, people have been receiving very unequal and not equitable treatment over time. So we have a lot of reparations to do on that. And innately, our connections with patients are from a place of hierarchy and power and authority. Medicine loves hierarchy and power, and we have to give that power back. And it's not about me telling people what to do or giving, it's about being a helper. What is it that I can offer to help in that journey with you? The second piece is around that social barriers. And I'm going to, again, I've given some examples of colonization effects over time. People are struggling with so many impacts of colonization and trauma. What's happening in families right now with toxic opioids, how many people are being lost who have young families. Resources are very, very limited. And so people are living in poverty. They're disconnected from their culture. And these are all things that people are coming to their visits with. And there's so much opportunity to actually help build people up by supporting them in the ways that had been holding them in a great place of health and wellness for centuries before contact. So we have to bring that back in and not be uncomfortable when somebody says, I met with an elder and they have provided me with this guidance for my health and wellness. That is to be welcomed. We can absolutely work with that. And it shouldn't be a choosing one way or another, but bringing all of the best of these things together so that we can achieve those outcomes. Now, the other aspect that I've had the privilege to work on in the last couple of years was that we were asked to help inform some rheumatoid arthritis treatment guidelines for the Canadian Rheumatology Association. And so we wanted to make sure that the guidelines that were being updated at the time thought about equity, and so that we were being conscious of, should we have different guidelines for different population groups? Should we be providing different implementation strategies for some of these? Are there baseline factors that we should think about where we want to make guidelines different because we need to address a different problem that people are experiencing from who they are in society? And so we went through and were able to accomplish creating guideline difference implementation aspects for different populations in Canada. I'll focus just on Indigenous populations today. But we approach this from understanding what are the unique population factors that people are experiencing. What are the difficulties with getting access to rheumatology care, for example, and then continuing in follow-up. And also specific pieces around medications, because that is, of course, one tool that's very critical in managing chronic autoimmune disease. And so from interviews with patients and providers and whatever we could find in the literature, we created what are contributors to inequity. And so what are the things that are actually making it different for one group versus another? And then what can we actually do to mitigate that? So to help reduce those barriers and try to use some of the facilitators to care in that as well. So this is specific to rheumatoid arthritis, but again, when you read the list, it's probably the same for lupus. From a population factor, so I've spoken a bit about the differences in disease severity. So there are things that are occurring that are more severe and more common in Indigenous populations. So those would be the areas to focus on as a primary approach. The second is that high frequency of comorbidities, so higher frequency of certain conditions that might make it more difficult to manage a disease like lupus or rheumatoid arthritis. There is a critical importance of social relationships and community. And so in a visit, it's pretty common that just the patient comes in. We're very, very worried about privacy in the healthcare system. And we want people to be able to share privately what is happening with them, and other people shouldn't be hearing that. And the approach that might be more appropriate in working with Indigenous peoples is that the family is really critical for support and is really critical in making decisions. And so we need to support having that autonomy to make a decision about whether I actually I don't want to make a choice about this drug or that drug in this 10 minutes that you're giving me. I need to think about it. I need to talk to my family members. I need to understand what's happened to other people who've tried this approach. So that's something that we really need to do. And then it's not just about the disease activity. It's actually about how people feel well overall and can address the things they need. So in the one community I'd worked with Sixica, we actually tracked for 7 years how people did with their rheumatoid arthritis. And we would look at, what are their swollen and tender joint counts, and what are their inflammatory markers, and what are, their function, and what happened to that over the course of 7 years of being followed in rheumatology care. And so I felt like a rock star, to be honest, because I thought, well, hey, everybody's got no tender joints, no swollen joints, inflammatory markers are down, we're doing great. And the patients were saying, well, no, my function is still really poor. My pain levels are still really high. And we said, okay, what is it that's not happening? And they said, well, it's, really nice that you come out once a month to see us. It's really nice that you have all of this approach, but you're forgetting about all the things that I'm living with for the other 29 days of the month. You're not you're not helping me connect to my culture. I still am living in poverty. I'm still not supported in my community because all the focus is on a diabetes support group or a cancer support group. Nobody talks about arthritis in our community. So we need you to do more to bring in all of those different elements of health and wellness support. And so we did. We found a model of care that we thought might work. We worked with the community to develop different facets of it. So we wanted someone from the community who understood the culture, who knew who the elders were, to help put people in contact with those community connections. They were there to help navigate access to healthcare. So if a flare was occurring, they knew who to call, and then they knew how to get a hold of the appropriate provider depending on the type of flare that was happening. So that's one way that you could do things differently. That healthcare access piece, again, racism is a significant component of that story. And you might have a rheumatologist, for example, who is not racist and who provides a very trauma-informed care approach, but maybe the clerk who's making the reminder phone calls doesn't have that same approach, or the person who's monitoring the desk when you walk in for the appointment. So we have a lot to do around changing that entire culture of all the other health professionals involved in our clinics as well. Socioeconomics is a big piece. If you don't have the ability to take time off work to attend an appointment, if you don't have the funds to get 100 kilometers into where your provider actually is, then it's going to be difficult to access care on a regular basis. Distance is another factor, especially for people living quite remotely from where rheumatologists tend to cluster, which is in tertiary care centers. And then the health system navigation, as I alluded to, with needing to understand who is the right provider to contact for different concerns. Medications, we have to think about the fact that they're very complicated. They're difficult to understand. They do put you at high risk for side effects because they're suppressing that abnormal immune system. And so we have to work to build trust that we are going to be monitoring for side effects, that we do know these things are going to work. And sometimes we need more data to do that reliably. And we have to think about coverage. So if you have treaty status and your First Nations, you probably have access to First Nations and Inuit Health Branch formulary, which is different than provincial safety nets, which is different than people who have private insurance. So we have to make sure that everyone has access to what they need. When we were thinking of all of these different populations that we were doing this same work with, we noticed that many of the solutions ended up being the same. And so these were our top 5 health service solutions of how we work in a different way. And for organizations such as Lupus Canada, it's around how you can also help advocate for patients and changes in the health system to make these actually happen. So the first, I've spoken about our approach to improved communication and relationship building. So we need to work on how we actually improve those interactions between patients and providers. We have to think about how we increase access to care, working in different ways, working with different health providers. It doesn't always have to be the physician. There might be nurse practitioners or advanced healthcare practitioners in arthritis care who could be a part of this. And we also have to coordinate better. Lupus is a very complex disease. You probably need a kidney specialist and a hematologist or a blood specialist. You probably need people who are addressing pain. And so how do we all actually work together instead of in silos is another thing that we need to work on. Treatment options are very limited for certain conditions such as lupus. And we need to understand that the treatment options that we're providing are actually effective in Indigenous populations and have a safety profile that is acceptable and are things that people can actually afford and access as well. Collaboration is not just about medicine all the time. It's about us working with communities. It's about working with patient organizations. And it's about working with different providers who aren't a part of our health system whatsoever. So social workers, for example, are people who have lots and lots of knowledge around community access to resource, and we very rarely involve them. And then finally, advocacy. How is it that we actually work all together to help ask and mandate that these things actually happen over time? How do we make sure that patient voice is the most prominent concern that we have? And then people are saying that they don't have what they need. How do we work together to get that need met? So I'm just going to flip through this to go to this concluding approach that I'm hoping that all of you will participate in. Another colleague of mine developed these commitment to change statements as a way to think about, based on what I've learned today, what are things that I can actually do to advance my work in this area? So some of you on this are patients, some of you are Indigenous, some of you are healthcare providers, some of you are with different health organizations. So from where you are and who you are, what are 3 things based on today that you can take forward to change the story for lupus care and Indigenous peoples? What are the things you are going to do to help for reconciliation in your community and where you live? Think about these things, I hope, as you go through the rest of this week and reflect on the National Day for Truth and Reconciliation. As you go to other events, think about what it is that you can do to help support, again, what we need to do to help improve lupus care for Indigenous patients. So with that, I'll invite Ariana back to help with going through the chat or the Q&A that's happening. That would be great.
Thank you so much for your presentation. We do have a few questions. So the first question is, can you share any success stories or initiatives that have improved lupus awareness and support within Indigenous populations?
Okay, yeah, so I did introduce the aspect of what we had called the arthritis liaison with the Siksika Nation. And so it was not specific to a certain type of arthritis. It did have patients who had lupus in that group as well. And so the arthritis liaison was built on a patient navigation model. And we did this in collaboration with investigators at the University of British Columbia as well. And so we had selected a nurse who was from the community, and we provided her with more knowledge about arthritis conditions and all the different lupus and arthritis conditions, the different treatments, the different things to be on the watch out for as complications of treatment or the disease. And that person was located in the community, was able to, because they work for home care, logistically, they could actually go and do home visits and meet people in different locations around the community. Because one of the things is that healthcare providers are kind of restricted to working within the health center itself, and only home care had that ability to go out and do those visits. So part of that role was for her to very closely support individual patients. She was also given experience with how to do brief action planning and goal setting and work with people to set those. So some of the examples would be for pain management. She introduced meditative coloring to people, and anecdotally, people's pain levels decreased, and their requirement to use pain analgesics also decreased. And then the other aspect of what she did was to bring together a community peer support group. And so once a month, patients with arthritis and their family and supports would come to an evening. There would be food provided and an activity would be planned. So it might be a craft, it might be a sharing circle, it might be a knowledge session. But what it resulted in is that people felt like they actually had a network of people who were like them to share their stories with. And it created more of an awareness in the community as well, because more and more people wanted to come out and come to the arthritis peer support group network. So that was one thing that I felt was the most beneficial out of much of the work that we've done over the last 15 years or so. That one was a favorite. So
that sounds incredible, being able to bring the community together to do an activity and have everyone feel like they're in a safe space to be heard and share. Sounds great. Heather said thank you. We have another question that are there cultural factors or traditional healing practices within Indigenous communities that can complement or supplement lupus management or care? This might be a big question. It's a big question. So
yeah. Well, and I think it goes back to that heterogeneity amongst the different communities too in Canada. So each community will have its own knowledge of health practices and things that they do to support health. And some of these things in some communities, for example, some sweats are only for women and can only have certain participants. Other sweats are more open. And so it's difficult to pinpoint one specific practice because every community has its own approach. But saying that, most communities will have elders within them, and elders are there as guides. They are people that are confided in. They can use storytelling to help people see a solution to what they're navigating in time. So that would be something that I really encourage. It's a phenomenal support. They can provide ceremonies for healing as well. So I think that would be one aspect. There's also a lot of knowledge about the connection to land and how that can support health as well. And so the ability to have a place to go to connect to that land, again, will vary depending on where you live in Canada, but is something that certainly, and even from, I don't know if people follow like the evidence on forest bathing, but it helps reduce your blood pressure. It helps increase your well-being and improve your mental health. And so if you're thinking about that from you still need to contextualize knowledge to a Western lens, there is evidence of this, but that connection to land regrounds people to their beliefs, It's certainly beneficial for health outcomes to get out and be connected. And some people may live in a very urban setting, but there's different ways to connect to the land, even if you're living in an urban location. So I think those are all very important factors. And I think people probably are also thinking about traditional medicines and maybe herbs that are used. That knowledge is not something that I have the privilege to share, and is one that, if you are connecting to your community, may be shared with you, again, through elders or traditional healers in the community.
Thank you. Final question. Oh, sorry. Actually, there is not. So, does NIHB offer comprehensive support when it comes to treatment options like lupus requires?
Short answer, no. It's difficult. So NIHB, for those who aren't familiar with it, it's the non-insured health benefits branch, and it's the federal support, mostly for medications, but it also will cover things like assistive devices. It's where you would get your foot orthotics, your walking devices. It can be where you access some dental care. And there's a fifth component of it that I'm just blanking on right now. But that basically will cover those needs to some limited extent. It is not a fulsome, comprehensive program, that's for sure. But every community, again, has a bit of a different agreement. So you may live in a community where you do have the band saying, I'm going to take some of this health transfer money and apply it to supporting a mental health initiative in my community. Or it might be that we will provide transportation to get to a place where you can access all those supports. Or we've got extra funding to bring in a physiotherapist to work in the community. So there are those nuances to it, but the NIHB program itself, no, technically does not provide comprehensive support. I'm not sure, some people might be familiar with Jordan's principle. And Jordan Anderson was a boy born with very complex health needs in Manitoba. And he was spending the first few years of his life in hospital, being, basically brought to a place where he could return home and live in his home community. And that did not occur because there was fighting between the provincial government and the federal government about who was going to pay for what. And it was things like who was going to pay for the shower head in the home, who was going to pay for respite care. And so as the government tried to sort this out, Jordan ended up becoming 4.5 years old and dying in hospital, never actually having been discharged because of that government fighting. And so Cindy Blackstock and the First Nations Society actually sued the government over this. And as a result, there's now a new policy in place called Jordan's Principle, which means that people get access to what they need to do for their disease first, and we worry about who pays for it after the fact. Sort it out, don't catch people in the middle of it. Unfortunately, Jordan's Principle only applies to children at this time point, and we absolutely need a Jordan's Principle for adults so that we can do this. And again, worry about who pays for what on the back end and not at the face of patient care.
Absolutely. And then there was another comment that just says the urban population should be included in the support system for lupus and arthritis.
Yeah, absolutely. It's difficult when you're not connected in a community that has, a health center at the center of it. So most cities now do have urban Indigenous clinics. And there are some very promising practices there where elders are actually a part of the health clinic staff, so that they are accessible to people. There are people who help navigate some of the social agencies in cities, but certainly it is more difficult to connect in the urban setting. Absolutely.
And then someone else has just said, thank you for a wonderful and informative presentation.
Thank you.
Thanks
Um,
to Dr. Barnabe. That was wonderful. I've been making notes as you've been speaking, and there's just so many interesting points that you made throughout your presentation that, I personally want to take and digest and see how we can better support the Indigenous population that live with lupus. So I really appreciate your time today to be able to share all this wonderful information and, to hear more about that Jordan's principle. That is incredibly sad. And hopefully there can be some sort of something put into place that's similar to that for adults. No one should have to endure that.
and someone else has just said, many thanks, Dr. Barnabe, for this insightful presentation. And yes, thank you everyone for joining us today. We do have our monthly donor program called Give 12, and this program allows Lupus Canada to keep, giving these educational webinars, to keep funding research and working towards our mission of creating a life without lupus. So thank you to our donors right now, and thank you also to our sponsors, AstraZeneca and GSK, that also allow us to give these informative webinars. And Leanne, I don't know if there's anything else you'd like to add.
Yeah, just really appreciate Dr. Barnabe's time and everybody's time today that was able to join this webinar. It will be, as Ariana probably will note, it is being recorded and it will be available on our website within 24 hours.
Thank you again, Dr. Barnabe, for joining us. And that I think is it. So thank you, everyone, and have a great rest of your day.
Thank you.
Bye.
Take care. Thank you, Ariana.